So posterior segment trauma management always it appears to be difficult and complex to many of us. Basically, it is a misconception that posterior segment trauma always comes with unpredictable outcome. But in reality, trauma purely follows the law of nature. Trauma doesn't follow the segment concept that we have created. So the assessment is a little bit cumbersome and intervention itself. The basic clinical assessment that we look into, first we have to know whether this is a reversible or irreversible damage. Involvement of the visual axis, is there any sign of presence of infection, and if there is any presence of intraocular foreign body or any associated reaction. Some other prognostic factors that are usually important is initial vision. The initial vision will guide the final outcome in many instances. The type of trauma, whether this is blunt or this is penetrating, and exactly the location of most impacted site, whether macula is involved, and if it is a injury, penetrating injury, the size of the wound, the extent, and one important aspect is duration. And there are certain diagnostic aids that my next speaker will go ahead. So these investigations will help you to guide in your management. Suppose if there is a media is hazy, if the ultrasound will guide you. And VP is very crucial. Sometimes in trauma cases, we are not sure about the perception of light. So in this kind of cases, VP will guide you whether will intervene or not in very severely injured eyes. And ERG will give a hint if there is any unlocalized intraocular iron foreign body. In long run, there may be some reaction. So ERG can guide you in managing these cases. Angiography, if subtle macular sense there, and OCT is a new instrument tool which is helpful. If we come case by case, the scenario one is blunt trauma. If it is a Berlin's edema, then the prognosis is good. Usually Berlin's edema, it resolves spontaneously without any medication, but you can add the anti-inflammatory or steroid mild, but basically the prognosis of Berlin's edema is good. If it is a retinal dialysis related retinal detachment, still prognosis is good. With simple buccal surgery, you can settle this retina, and visual prognosis is good. If it is a vitreous hemorrhage, but the posterior segment like the macular and is fine, there is no such severe injury, only vitreous hemorrhage, you have excellent outcome. And choroidal rupture depend on the site, it may have an average outcome. It is away from macula, the prognosis is good, but if it involves the center of the macula, it may not be as well. And a posterior lens dislocation, always the prognosis is good with surgical result by surgery. And submacular hemorrhage along with choroidal ruptures, this is average outcome, again depending on the extent of macular injury. Macular hole, usually traumatic macular hole, prognosis is not good. And if there is associated traumatic optic nerve involvement, it is always poor. And if it is a combined traumatic CRVO, again this is not that good. Sometimes associated optic nerve avulsion in trauma, of course this is not good. The vision is outcome is poor. And in penetrating injury, only vitreous hemorrhage, again the excellent outcome. If you do primary repair or under table, if you do repair and go ahead with vitrectomy, excellent. If macula is healthy, outcome is excellent. Fresh retinal detachment, this is average outcome. Vision, of course, it's not bad. But if it is a GRT, then of course the visual outcome is not that much good. It's poor outcome. Globe rupture always comes with poor outcome. And if you see pictures like this, of course, late changes, is a poor outcome. And intraocular foreign body, if siderotic change is developed with time, then it may not come out with a good result. But a foreign body, if it's a fresh injury, if it is not involved in the macula, with surgical results are good. endophthalmitis, the traumatic endophthalmitis, always it result is not that good. It's a poor outcome. And even the managing traumatic endophthalmitis along with intraocular foreign body, we have topics with our teachers. They'll come. These are challenging cases. Results are not that good, but we can save these eyes. And if there is sympathetic ophthalmia involving the other eye, then it's poor outcome. One very important aspect of trauma is the OTS, this ocular trauma score. It determines the patient's initial visual acuity after the injury and their tissue diagnosis. So assign a raw point value for initial visual acuity, as I'll come to that in the next table. From row A in table 1 is coming, and then subtract the appropriate raw points for each diagnosis from row B to F in table 2. You just go at the two tables there. Table 1, the computational method for devising the OTS score. Initial visual factor, you will give a scoring depending on the visual, and on the tissue diagnosis we will give this negative scoring. So estimated probability of follow-up visual acuity will come like this. Suppose the raw sum score is somewhere below 44. These are the probability of vision by 6 months. So this helps you to counsel the patient what is his ultimate outcome. You can refer to this OTS. So higher OTS scores tend to indicate a better prognosis. To provide an estimate of the patient's probability of attaining a special visual acuity range at 6 months follow-up, as I have shown, you locate that from this. Suppose his score is 66 to 80%. So he is having good chance to have a better vision. And if it comes in this range, of course, this is good. And this is a big study that's shown different outcomes of posterior segment trauma. So main reason of functional failure, they indicated macular damage, retinal detachment with PBR, and optic nerve injury. So the important prognostic tips that I want to give. First, we have to see whether infection or inflammation. Penetrating trauma with hypopion, always think of endophthalmitis first. So never confuse that it can be a case of inflammation, not infection. But in penetrating trauma, if you see hypopion, you go in the line of endophthalmitis first. And if base-corrected visual acuity is inappropriate with your clinical finding, then think of involvement of other structure like the optic nerve. So if visual correct BCVA is not just inappropriate with your other clinical finding, then you have to think of involvement of optic nerve, and RAPD, evaluation of RAPD is important. And if iron foreign body, you go